All right. I'm so excited to be introducing Dr. Jessica Schleider. And can folks hear me? Can I get a thumbs up? Am I okay? All right, great. Um, Dr. Schleider is the director of the Lab for Scalable Mental Health and associate professor of medical, social sciences, and pediatrics and psychology at Northwestern University. Her professional mission is to build, test, and disseminate scalable, evidence-based mental health solutions that bridge gaps in mental health ecosystems with a focus on single-session interventions for underserved youth. In support of her work in this area, she has secured over $7 million in federal funding, NIH, NSF, HRSA Foundation funds, and industry funding as PI or project lead. Dr. Schleider has been recognized via numerous national awards for research excellence and innovation, including the NIH Director's Early Independence Award, and she was previously chosen as one of Forbes 30 under 30 in healthcare. Dr. Schleider has published over 110 peer-reviewed articles. She's also created or co-created 7 open access single session mental health problems. Yes, Dr. Glowinski, she is awesome. Which has reached over 50,000 people to date. Based on, I'm sorry, she also created this is important, co-created 7 open access single session mental health programs, which have reached over 50,000 people to date. Based on these programs, Dr. Schleider and her colleagues wrote a self-help workbook, the Growth Mindset Workbook for Teens. She also co-edited the Oxford Guide to Brief and Low Intensity Interventions for Children and Young People, and wrote a nonfiction book, Little Treatments, Big Effects, on how single session interventions can transform mental health. Dr. Schleider completed her PhD in clinical psychology at Harvard University in 2018, along with her doctoral internship in clinical and community psychology at Yale School of Medicine. It is such an honor and a pleasure to welcome you. And I'm sure you can maybe feel the virtual claps happening all around and welcoming you here today. I'm going to go ahead and mute myself and give you the floor.
Thanks so much for the opportunity to share our team's work with you all today. I'm so excited to be here. I'm going to share my screen and dive right in because there's a lot to get through, and hoping to leave some time at the end for any questions or ideas that folks want to share. All right. So just up front, want to highlight that the work I'm going to share is the product of a whole lot of faith that folks have had in our approach to this science. And we're very grateful for the support we've had from government, funders, nonprofits, city, industry folks. And it's been really wonderful to be able to collaborate with so many people across sectors. I get book royalties for things related to this talk, and do some consulting on helping people disseminate single session approaches. So I realize I'm preaching to the choir when I say our current mental health care system is not enough, but I want to highlight that meaningful expansion of youth mental health services in particular, I think requires us to reckon with 3 really unfortunate realities. Reality 1 is that between 50 and 80% of youth with significant mental health needs in the United States do not access any form of professional support. So the interventions and treatments we have that are currently available to folks are very obviously missing large swaths of the population. Reality 2 is that the supports that do exist are often structurally incompatible with how many young people want to engage with services. When we ask young people in our mixed methods work, what would your ideal mental health support actually look like if you could build it from the ground up? What they don't say is once weekly therapy. They say things like, I want treatment on demand when and where I actually experience problems. I want it anonymously or confidentially on my own terms. And I don't necessarily feel comfortable going to adults in my life for seeking out treatment. I want to be able to access things independently, which is very, very different from the mental health care system that we've built. Reality 3 is that based on national insurance reimbursement data, The most common number of interactions that folks actually have with mental health support happens to be 1. The average is around 3 or 4 before discontinuing treatment, which people are forced to do due to a variety of logistical, financial, personal barriers to accessing care. The modal number of sessions is 1 number, is backed up by international data from Japan, Spain, the UK, and a variety of other countries, Australia. And it really is a stark reminder of the fact that we've built treatments that don't fit at all how people actually interface with services, even if we prefer that they interface with services differently. So given these realities, the goal of our research team broadly is to design, test, and disseminate brief, barrier-free interventions to reduce mental health problems at scale, at the population level, rather than for the individuals who are fortunate enough to be able to access gold standard interventions. To accomplish this, we take the approach of focusing on single session interventions, which are a particular variety of scalable interventions. I want to start off with a definition just so we're all on the same page about what exactly do I mean by SSIs, or single session interventions. We refer to them in our lab as specific structured programs that intentionally, and that's key, involve just one visitor encounter with a clinic, provider, or program. In other words, an intervention that's designed to provide a clinically meaningful dose, not necessarily a clinically sufficient dose, but a clinically meaningful dose of intervention in one session. I say intentionality is key here because attending an intake for what is assumed to become a longer-term course of treatment, but not being able to continue in treatment, that intake session wouldn't be considered a single session intervention, even if accidentally only one session was accessed, because there wasn't a shared understanding that, okay, we're going to make the most of the time we have now, whether or not there are additional sessions to work together on this issue. SSIs may be accessed on one occasion or on many occasions. That is, this is a one-at-a-time approach. There's no expectation that a single session will solve everyone's problems. That's neither realistic nor helpful for the person receiving support. The idea, rather, is that one session can matter in some kind of way that could have a ripple effect on future behavior and emotions. SSIs can be self-guided or human facilitated. I say human because they don't necessarily have to be professionally delivered, and I'll get to that soon. And they may be accessed within or outside of formal healthcare settings. So they're quite flexibly adaptable to different contexts, hence the scalability potential of this approach. In all of these cases, what SSIs have in common is they drop this often false assumption that clients can and will necessarily return for session 2, while instilling the belief, which happens to reflect the data, that meaningful change is in fact possible at any moment, even if that moment is quite brief. And as I mentioned, this isn't just a good idea. There's a lot of data to back up this claim. Really excited to be, our team is currently conducting an umbrella review of all systematic reviews of single session interventions for mental health problems across the lifespan. This is a 2017 meta-analysis that we did. I'm really excited to be able to update this slide after several years. But bottom line is decades of research do tell us that single session interventions can help. In some, but of course not all cases, they can help in ways that are comparable to multi-session treatment. What you're seeing on this graph are the meta-analytic effect sizes for single session and multi-session treatments, single session in blue, multi-session in red, for youth mental health problems, specifically anxiety, conduct problems, and depression. On the y-axis, you can see the average Cohen's d meta-analytic effect for each of those intervention categories. Now, the most striking thing to me about this graph is that those bars are much closer together than you might expect them to be. They certainly were closer together than I expected them to be when I was first putting this paper together. And after checking and rechecking to make sure this wasn't a coding error, it actually was the state of the literature, we concluded that, my then advisor, John Wise, and I concluded that there is clearly something that can be beneficial about one session of treatment. It's just a matter at this point of figuring out what about one session can be helpful and how do we optimize that so that more people can access it. And I want to pause to highlight that SSIs cannot and will and should not replace other forms of mental health care treatment that are already out there in ecosystems of support. But the problem is other forms of healthcare treatment that are already out there are completely insufficient to meet population level needs. So I'm trying to share data to suggest that single session interventions are in a wonderful position to help fill some of those gaps that traditional treatments simply weren't supposed to fill. They weren't built to in the ecosystems of care we have today. So since 2016, when I started doing work on SSIs, or single session approaches, a lot has happened. I founded our lab in 2018, and in the past 5.5 years, we've been doing a lot of intervention development and dissemination. To date, our evidence-based SSIs, which are mostly digital self-guided interventions that last between 10 and 20 minutes, have now served more than 50,000 young people and parents. About 15,000 plus of those are through grant-funded RCTs, but more than 35,000 have actually been through nonprofit and community partnerships. And we've been really lucky to be able to form international collaborations that have led to translating our single session interventions into 8 different languages. We're just now finalizing a couple more into Polish and Ukrainian for a new study. 2 of our single session interventions have been certified by a really wonderful org called Blueprints for Healthy Youth Development as being dissemination ready. What that means per Blueprints criteria are not only do these interventions show in multiple independent clinical trials that they're effective at reducing adolescent depression, but we've also shared all of the intervention materials openly and publicly through Creative Commons licenses and through our website, which I'll share with you in a moment, such that anybody can actually use the interventions at any time as and when they need to. Our programs have been built largely via co-design with youth who would otherwise be systematically excluded from mental health research and treatment, such as sexual and gender minority young people, largely because these are the majority of who access the interventions that we create, especially when we create them such that they're publicly accessible anonymously with or without parental involvement. We now secure parental consent waivers for all of our research with adolescents, precisely because, well, I'll share more of this work later on, but youth often identify parents as key barriers to accessing mental health care. And we want to make sure that youth who aren't in supportive homes, which overwhelmingly tends to be minoritized young people, have equal access to the materials that we create. So we've developed a variety of different single session interventions that are self-guided or human facilitated at this point. They all are slightly different in some form or another. I'll share more about the common theoretical model and theory of change, but what they have in common is that each one targets a modifiable short-term belief or behavior, whereby short-term improvements in a target, so perceived control, perceived autonomy, or hope for the future, can spur upward spirals over time of meaningful longer-term change. And our follow-up periods have ranged generally from 3 to 9 months in randomized controlled trials, which all have active controls. We're currently wrapping up a study with a 2-year follow-up testing 2 different single session interventions. So I'm excited to be able to share some of those findings soon. In terms of how we go about constructing single session interventions, it's more than simply identifying what might be helpful about a longer term treatment. We've really tried to draw from marketing research, social psychology, and affective science to identify what elements of a brief program would the short window of time where we're going to have somebody's attention, especially a young person, to enhance memory for the content, relatability of the content, and meaning of the content for future outcomes. And we've landed on a few different components. And we call these the best elements of SSIs for youth mental health. B is for brain science, but we've really expanded this term to mean science in general or objective facts in general. We use scientific ideas such as neuroplasticity, the idea that all brains are built for change, to normalize the concepts we're teaching, such as growth mindsets of depression, that depression is malleable rather than fixed. And what we're trying to do there, particularly for teens, is to strengthen buy-in to the ideas that we're sharing. So it's not just random adults saying this, it's actually just scientific true facts, and you can use them as you want. And also to normalize the concepts that we're teaching, such that this information applies to everybody, not just people with clinically significant difficulties. Everyone has potential for change, for example. E is for empower. We try to empower youth to the helper or expert role. We do this by, at the introduction of the interventions, telling youth that not only did they stand to benefit from the information that we're going to share with them through this program, but we're also going to be seeking their help in helping to explain and communicate the concepts that we're sharing with others who are struggling. So that immediately puts youth who are receiving the program in the helper or expert role rather than the passive patient role that many of them are used to if they've been in treatment before. S is for saying is believing. We include opportunities for youth to read hypothetical stressor scenarios for peers who are struggling with similar mental health difficulties, and it helps them navigate those difficulties using the skills they just learned in the intervention. So basically learning by teaching. And that helps them sort of consolidate the information they just read about, and also going back to that empower piece allows them to take sort of a leadership role in owning this information. And T is for testimonials or stories. We include a lot of narratives that we've collected over the years from adolescents with lived experience of mental health challenges. And this essentially makes the content memorable. Stories are affectively salient, they stick with you, and this is often the part of the interventions that teens highlight as being their favorite. All of these best elements really boil down more simply to self-determination theory, which is a well-established social psychological theory of behavior change, wherein all humans have basic psychological needs to feel competent, autonomous, and related to others. And those are the exact targets that SSIs have been shown to shift. They've been shown to help people feel more efficacious in terms of their coping, more in control of their outcomes, and more related to others in similar situations. And we've seen also in a bunch of trials at this point that shifts in these short-term outcomes, competency, autonomy, relatedness, are actually predicting larger improvements over time in anxiety and depression following a self-guided SSI. As one example of a relatively recent RCT we ran, this is a project that we conducted during COVID, when many, many young people across the country were actively losing access to mental health treatments, both in schools and in outpatient settings. We were able to secure NIH funding to conduct a nationwide randomized controlled trial for which we recruited youth entirely on Instagram over 3 weeks. To see whether digital single session interventions for depression could reduce symptoms in youth with clinically elevated problems. We tested a behavioral activation intervention, the idea that what you do can shape how you feel. You don't have to feel better before behaving in ways that might support progress, and a growth mindset single session intervention. The idea that because all of us have potential for change because of neuroplasticity, depression, anxiety aren't things that are part of our identity or part of who we are inherently. They're things that can be changed through different coping skills and supports. So in this NIH-funded RCT, which included 2,452 teens across all US states, about 20% were in rural parts of the United States, 80% were sexual and gender minorities, and 50% racial and ethnic minorities. We found that both online single session interventions led to significant reductions over 3 months in depression symptom severity compared to an active control. The control we typically use in our trials is basically a placebo SSI. It's an interactive 15-minute computerized activity that people can complete on their own that teaches that sharing feelings is good. Doesn't teach any skills for how to share feelings or provide any of the other elements aligned with self-determination theory that are in our standard interventions, but it is designed to mimic something that seems helpful. So compared to that active control, we found significant effects for both interventions. Both interventions also significantly improved hopelessness, and project personality, the growth mindset intervention, also led to improvements in anxiety symptoms. To our surprise, both interventions also led to significant reductions in restrictive eating behaviors, which has since sparked a new line of research among our team of single session interventions targeted to body image and eating concerns, which we're really excited about. Because we were able to secure a really diverse sample for this study, we were able to do a fine-grained analysis of equity and acceptability and outcomes. And we did actually find that effects of our interventions did not differ by race, ethnicity, sexual orientation, or gender identity, which was really very exciting because many times evidence-based treatments are not actually performing equitably in different populations. So we were really happy to see that. I want to note that I think the reasons we were able to recruit, or the reason we were able to recruit such a diverse sample in such a short period of time using social media approaches, was because we waived parental consent requirements. So adolescents could self-refer if they perceived a need for mental health support to screen into our study. That's not the norm at all in youth mental health treatment research, but it's something that we've since been able to argue at 5 different university IRBs now on ethical grounds. That we need to allow teenagers to determine whether they're going to access low intensity mental health support. So if anyone is curious about our approach to that or wants IRB justifications or materials, I'm more than happy to share because I really would like to see this being more standard. So a natural question that these results beg is, okay, so they don't seem to be working differentially for different racial or ethnic groups or different sexual minorities or gender minorities, but are there any detectable moderators of who might benefit from a single session intervention? And we now have more than a dozen RCTs to draw from to try to answer that question across multiple trials and contexts and populations. And the answers that I have right now really just amount to a list of things that don't moderate outcomes for SSIs. We haven't been able to detect any consistent moderators at all. So things like baseline symptom severity don't seem to moderate SSI response. What that means is that SSIs aren't just for young people who have mild problems. That was the working assumption that I had going into this work, that a brief light touch intervention could only plausibly be useful for somebody with low intensity difficulties. But we don't find that at all. In fact, people with more severe symptoms are more motivated to try a single session intervention when they're publicly offered in open spaces, and they're more motivated to get something out of it. So if anything, there's just a selection effect of folks with higher symptoms are even more likely to try an SSI, and the benefits don't appear to differ. Likewise, presence of self-injurious thoughts and behaviors don't seem to differ as a function self-injurious thoughts and behaviors don't seem to predict outcomes in the context of single session interventions, nor do a wide variety of parent level factors, potentially because youth are the ones receiving this intervention. And unfortunately, receipt of concurrent treatment also doesn't predict differential outcomes, potentially because what treatment actually is or means differs so incredibly broadly across contexts. So it's difficult to see any consistent effect there. One of our PhD students, Isaac Ahuvia, tried to take an even more rigorous approach to trying to identify, are there certain SSIs perhaps who work that work better for certain youth than others? And can we identify which SSIs for whom based on machine learning methods? So drawing from a personalized advantage index approach, a PAI approach is a machine learning based modeling approach that has actually successfully identified adults with depression who would be more likely to benefit from medication versus psychotherapy. We wanted to see if we could use a personalized advantage index approach to predict whether youth would be more likely to respond to a behavioral activation SSI or a growth mindset SSI, since presumably they target different ideas. But what we found in this study is, despite including hundreds of possible predictors from a large data set, response predictors of SSI response were so similar across the behavioral activation and growth mindset SSIs that treatment matching efforts really wouldn't have added much value in terms of clinical outcomes. So what we determined here is that increasing youth access to both digital SSIs and allowing them choice, thereby enhancing that mechanism we think is important of autonomy and competence and control, that choice may carry more public health utility than trying to forward additional SSI treatment matching efforts. And this has also got me thinking a lot about maybe timing is the important thing here, rather than delivering it to the right person. Maybe we need to be thinking about delivering these things at the right time in order to enhance their benefit, such as when needs arise. So recently, our lab made a big move. We moved from Stony Brook University in a psychology department to Northwestern, primarily in the medical school. And that shift was intentional, largely because we're working now on scaling up and cross-sector partnerships and integrating implementation science and thinking into our efforts to make SSIs available for everyone, make them ubiquitous parts of the mental health care ecosystem. And we've been trying a whole variety of different methods to get at this long-term goal. And together, the work that we've been doing recently and that's on the horizon for us is helping us understand the context, conditions, and populations where SSIs do and don't bridge gaps in healthcare ecosystems, and what kind of barriers we really need to be focusing in on in helping them reach more folks who otherwise would not access treatment. One strategy we've been using to implement SSIs is by linking primary care screening with SSI deployment. Within primary care, the American Academy of Pediatrics has promoted universal depression screening for adolescents. In theory, that's a great idea. It would be wonderful to be able to detect more reliably which adolescents are struggling with depression. But the problem comes up when you screen and you don't have any interventions to offer them right away, because the waiting lists for providers in the area are too long, or treatment is unaffordable, or insurance doesn't cover it for the families that you're referring. We wanted to see if we could offer single session digital interventions to parents and adolescents of teens who screened elevated during a primary care well visit on depression symptoms, to see if we could help motivate change just through those SSIs. So in this study, we were curious to see whether online youth and parent-directed SSIs teaching that symptoms can change can increase service access if paired with routine primary care depression screening. In this particular context, everybody in primary care received a list of possible places they could outreach, which were in fact available to them. But the uptake rate in the clinics on average was somewhat low, potentially because of lack of motivation or low hope that one of the outreach efforts would follow through. So we wanted to see if SSIs could help change that. And in our study, which included 160 families, we found that families who were randomized to receive SSIs in addition to just that list that I talked about were significantly more likely to contact a mental health provider within 3 months. And they were also significantly more likely to make a mental health appointment, get it on the books within 3 months, which I was really excited to see. I wasn't sure if this would translate into actual connection with services. But this study is one example, one that primary care-based delivery of digital SSIs is potentially feasible, but also that SSIs don't necessarily only benefit clinical outcomes like depression or anxiety symptoms, but may also help increase uptake or motivation of other kinds of supports within treatment ecosystems. Another dissemination strategy we've tried is making everything free. What I've learned from this work is that making things free on its own is a wildly insufficient implementation strategy. But nonetheless, we find it really important to our mission to make sure that all of the interventions we evaluate are publicly available after the trials end. So in that spirit, we've put together Project Yes, Youth Empowerment and Support, as a website, as a page on our lab website. And this is an open access anonymous program evaluation where anybody anywhere can access our SSIs in multiple languages that have been through clinical trials. We don't have all of them up here, but we have several in many different languages. And all of the questionnaires in Project Yes are totally optional. If you don't want to give us any survey data, you don't have to. You can just directly do the single session program. How Project Yes works is users first choose one of the activities that they'd like to do. They can choose whichever one they want, which is supported by the treatment matching study attempt that we did, showing that choice may be the best bet here. We then ask people taking the programs to tell us what they think. They certainly don't have to give us feedback, but this helps us iteratively evaluate and reflect on whether our interventions are remaining useful and relevant to the teens who take them. And then we ask users if they want to share their best coping advice with others. And if they do want to share their advice and they give us permission to share that advice anonymously, we add their written advice to other teens who are struggling in our advice center. So teens who take Project Yes are actively contributing to a resource that they can go visit and see where their contribution fits in for coping for others their age. So it isn't just hypothetical. We actually are asking teens to contribute to resources for others. We've run multiple pragmatic evaluations of Project Yes in different dissemination contexts on social media and in San Antonio public schools. We were really lucky to receive funding from the City of San Antonio Metropolitan Health District to culturally adapt and translate Project Yes entirely into Spanish, and to work with teen advisors from San Antonio who are bilingual to weave their own personal narratives of coping and recovery into the programs themselves. And in that rollout, which we conducted in about 1,000 San Antonio teens, mostly via public schools, we found that the interventions were acceptable and linked to improvements in self-hate, as well as perceived control and hopelessness from pre to post intervention. The programs were also equally acceptable and effective in English and Spanish. So another approach we've taken to addressing really wide gaps in access to mental health care is not just by targeting adolescents, but also by targeting their parents, specifically with respect to efforts to reduce child anxiety. I'm really excited about this because we just got the results of a new RCT of Project Empower, and I'll share the results with you in a minute, but I'll be able to update the next slide within the next couple of weeks, but I didn't have time because it was just this week. So Project Empower is an intervention designed for parents of youth with anxiety. And this intervention was based on really fascinating research, at least to me, coming out of the Yale Child Study Center on a multi-session clinician-based program called the SPACE program, developed by Ellie Leibovitz. The SPACE program teaches parents what parental accommodation of anxiety is and why accommodation, although it may work in the short term to reduce their kids' distress, is ultimately taking opportunities away from young people to learn that they can handle difficult situations. So the intervention is designed to reduce parental accommodation of anxiety and help parents boost brave behaviors in their kids, or approach behaviors in the face of anxiety-provoking scenarios. Project Empower aims to do what Project Space aims to do, but in one single session self-guided program. There's a hedgehog in Project Empower because Emma Mumper, who was the co-developer of Project Empower, loves hedgehogs, and now there's a permanent hedgehog in the intervention. Our initial trial of Project Empower, led by Jenna Sung, who just matched for internship, and one of my PhD students, the new trial is her dissertation, actually. We conducted this study in 301 parents with high anxiety because we know anxiety runs in families. And we wanted to see whether Project Empower could reduce parental accommodation and improve parental distress tolerance. Why distress tolerance? Because in order to successfully reduce your accommodation of your child's anxiety, you also have to be able to tolerate the distress of seeing your child in distress due to anxiety. So they're really intertwined with each other, and we would need to see impacts on both outcomes in order to be confident that this would be helpful for prevention over time. In our first trial of 301 parents, we did find that Project Empower significantly reduced parental accommodation of child anxiety compared to an information-only control, and it reduced it improved parental distress tolerance. And this was very exciting to us. The effect size rates are really promising. What we just found in Jenna's new study, which focused on financially insecure families, was that not only are we seeing replication of these effects on parental accommodation and distress tolerance, but we're also seeing a large effect of the intervention on child anxiety symptoms at 4-week follow-up. So really excited to be able to share more about that soon, but just a preview of what's behind the scenes happening at this point. We were also excited to partner with Dr. Jill Ehrenreich-May to translate and adapt Project Empower for Haitian Creole and Spanish-speaking caregivers. Most of the research that's been done on parental accommodation of child anxiety has focused on higher income white families. And so we actually weren't certain that the content would resonate with families who have a whole different set of challenges and concerns with regard to parenting and child behavior. But fortunately, we did find that with a few adaptations to the kinds of examples and stories from the interventions, we were able to create a version of this program that was acceptable and feasible. All three of these versions, translations, are publicly available on our lab website for anybody to use. I mentioned earlier that we had that surprise effect in our recent RCT of youth across the country with depression, of seeing effects of depression-focused single-session interventions on restrictive eating behaviors. Those were unexpected findings, but it did spur a lot of interest within our research group on whether we can successfully target body image difficulties, which are so highly comorbid and intertwined with depression symptoms, whether we could target both at the same time in the context of a single session intervention. And from that idea or question, Project Body Neutrality was born. This represents work that's been really led by Ariel Smith, a member of our lab team. Project Body Neutrality is an SSI that teaches that valuing your body based on what it does for you, even if you're not always happy with how it looks, can help you cope with body image difficulties and with low mood. Body neutrality emerged largely in advocacy spaces and among folks who are involved with eating disorders advocacy and research as a sort of response or reaction to the body positivity movement, which a lot of people find to be invalidating. The message overall there is just love your body no matter what. And a lot of folks find that extraordinarily challenging to actually do, and they feel distressed when they can't just simply love how they look. Body neutrality takes the emphasis off of appearance entirely and helps people appreciate their bodies for what they allow them to achieve and do in the world rather than what they look like. We found that in an open trial of 76 young people with both elevated depression symptoms and elevated body image difficulties, the Project Body Neutrality was associated with increases in functionality appreciation, declines in body dissatisfaction and hopelessness, and increases in a sense of agency. So we were able to move both those markers like hopelessness and agency that we see reliably changed in our depression-focused SSI trials, but also body image-specific outcomes like body dissatisfaction, functionality appreciation. We're about 40 people away from meeting our 250 N target for an RCT of Project Body Neutrality with a 3-month follow-up. So I'll have more data on more rigorous outcomes on this intervention very soon. I spoke briefly before about the importance of timing. So not just who are we delivering these SSIs to, but when are we delivering these SSIs? And that's work we've been able to pursue and explore really thoroughly in our partnership with an organization called COCO. COCO is a digital mental health nonprofit organization that contracts with social media companies to embed mental health tools directly into social media platforms like Tumblr and Pinterest and Meta. Such that when people on social media search for terms like depression or suicide or therapy, COCO automatically pops up and offers them supports. Historically, COCO's supports that they've offered have been in-the-moment peer-to-peer support, crowdsourced peer support. It's a really cool model, and I encourage you to read about it. But what I connected with COCO about was the idea that single session self-guided interventions could be another tool that COCO could offer people in those moments of automatically detected need. So we went ahead and embedded a couple of our SSIs that had already been through clinical trials into COCO and saw how they worked, not in an RCT, just in a general rollout to see whether people liked them and whether they were helpful. In this process, the SSIs that we decided to embed into COCO were reduced in length dramatically from 25 minutes to 6 minutes. Why? Because that's how long somebody will do something on the internet if they are not being paid to do it as part of a study. We tried to retain the core elements of our interventions, so those self-determination theory components, stories from peers, and opportunity to give advice, brief psycho-ed, and just naturalistically through COCO's platform, our SSIs were completed by over 6,100 teens within 1 year of deployment. And we were able to benchmark immediate impacts of these SSIs based on what we've seen before in our randomized controlled trials. And benchmarking in this way, we were able to show that hopelessness in the context of our SSI when they were deployed publicly on Tumblr resulted in just as large of decreases in hopelessness as they did in our RCTs. But completion rates in the Tumblr versions were a whole lot higher because they were shorter. That's not a shocking finding, but it was really exciting to see that we can retain the impact while dramatically reducing the content, which I think speaks to how attached we all are to some of our intervention content, when a lot less could probably suffice. We've also leveraged SSIs within COCO's platform, not just to reduce hopelessness and problems directly, but to increase people's receptivity to using crisis resources. One of COCO's main goals is to help people in crisis identify resources that could help them navigate that mental health crisis. And along those lines, almost all social media platforms that COCO partners with and in general have built-in AI algorithms to detect whether users might be in crisis. For example, if you go on Instagram right now and search for suicide, you're probably going to get a pop-up like this. The National Suicide Prevention Lifeline, probably now 988, is included in their crisis text line. But the problem with this pop-up, even though it is sort of the bare minimum that these platforms can do, is that not a lot of people use these things when they pop up in this way. Qualitative research suggests that folks perceive these pop-ups as being impersonal, perfunctory, kind of legal requirements of the platforms, and usually don't bother following through. We wanted to see if a 1-minute single session online intervention delivered through COCO in a brief written out chatbot could help people be more likely to try out one of these crisis resources when they're detected as being high risk in social media platforms. And we found that our 1-minute SSI, which included a 1-sentence piece of psychoed, a quote from a peer who used a crisis resource, and a choice of which crisis resource do you want to use, actually doubled uptake of resources at moments of potential crisis, from 38% uptake to 78% uptake. And this was in an RCT of 355 youth recruited via a wide cross-section of social media platforms. This is now COCO's standard approach to supporting folks that they identify in crisis on their platform. Other work we've done has focused specifically on the needs of marginalized and minoritized populations, and for us, a particularly important subset is sexual and gender minority teens. Since across a lot of our trials, as you might have noticed, that's a big portion of who accesses our interventions. We were fortunate to get some funding from the Upswing Fund for Adolescent Mental Health to adapt our interventions, our existing SSIs, with and for sexual and gender minority young people as part of an advisory group that we put together. But what we learned from those focus groups was not that our interventions didn't apply to their needs. Behavioral activation was still relevant for sexual and minority and gender minority teens. But what they did tell us was that, none of these interventions talk about how difficult the world is right now, how hard it is to live in this political climate, how stressful it is to not know if I'm safe wherever I go in the world. And they're talking about minority stress, and they're absolutely right. Our interventions didn't touch on that at all. And rather than trying to tack on a little bit about minority stress to one of our existing interventions, which would be, I think, pretty inappropriate, we decided to just work with the teens to build a new single session intervention altogether. So that's where Project RISE came from. Project RISE is an SSI that teaches about minority stress theory, and how oppression works to worsen mental health outcomes for populations that hold oppressed identities. We talk about intersectionality, but focus on folks with sexual minority and gender minority identities. We also help people identify ways to cope even in spite of an unfair world that makes things legitimately harder for them sometimes. We help them identify personal strengths and social resources they can use in times of distress. In an RCT of 538 sexual and gender minority teens, ages 13 to 16, we also obtained a parental consent waiver again and recruited via Instagram. We found that Project RISE led to significant improvements in hopelessness, self-hate, and internalized stigma versus an information-only control. It also led to increased identity pride. Some of my favorite feedback from this intervention from youth was along the lines of, thank you for not painting a rosy picture of this. Yes, one kid said, thank you for telling us thank you for acknowledging that it's not all rainbows and pride flags. And so I think part of the reason this intervention might have landed well is because it felt very validating to very real experiences that youth had been going through. And it also helped them find solutions when a lot of the time solutions feel like they might not exist. We also have human-delivered interventions, or one at least. The single session consultation is something that I developed as a waitlist-focused intervention. It's a single session program based on solution-focused brief therapy, not cognitive behavioral therapy. They're very different. As in, this is a strengths-based intervention that helps people do more of what they can already do rather than helping teach new skills. But the idea here is that people, for example, seeking treatment in outpatient settings, they don't necessarily want a digital program. They've called the outpatient clinic because they want to talk to a human person. And so what often happens is people reach out for outpatient services and the person who answers the phone says, great, thank you for reaching out. It's really hard to ask for help. Proud of you. Now maybe wait 6 months while we hopefully get to the top of our waiting list in our clinic. And that's really demoralizing. It crushes the motivation that people have already had in reaching out for care in the first place. And people actively get worse while they're waiting for treatment. So the SSC is one possible approach to preventing that waitlist effect, the harms that waitlist can do, by offering somebody a one-session solution-focused program immediately when they reach out for care to prevent deterioration while they wait and probably increase hope and motivation for treatment at the same time. So can a therapist-delivered solution-brief therapy-focused SSI reduce hopelessness, increase agency, and keep symptoms from worsening for people on waiting lists for treatment? It's a really simple intervention. I'm more than happy to share more resources and materials about it. This, just to give you a sense of how simple, is the entire intervention. I put it together with the hope that it would be delivered by motivated college students, not by licensed professionals, although that is a good portion of who's delivering it at this point. And we've found in multiple clinical trials at this open trials that the single session consultation, when offered to folks on waiting lists, not only is taken up by a large portion of people, but is helpful in reducing hopelessness, increasing readiness for change, and even reducing anxiety and depression, which is the opposite of what we typically see while waiting for treatment. Oops. More recently, we collaborated with a wonderful organization called Strong Minds, which is located in Uganda and Zambia. Their model is a peer specialist delivered approach to mental health support because Uganda and Zambia have such massive provider shortages. And we trained 4 of their peer specialists to deliver the single session consultation. Strong Minds model is delivering group-based interpersonal psychotherapy delivered by peer specialists, but even they have a waiting list. So the single session consultation was designed to help people immediately upon outreach. The SSC by Strong Minds was offered both individually and actually in groups ranging from 2 to 6 people, purely out of convenience, not because of any hypotheses we had. They just had a lot of people who were waiting for treatment. And they were delivered by lay community providers. And everybody in this sample had depression at the time of outreach, PHQ-9 score of 10 or greater. And in a sample of 196 service-seeking Ugandan adults, ages 18 to 69, we found that the SSC on average led to clinically meaningful drops in depression symptoms across 4 weeks while people were waiting for treatment. There was no control group here, but the drops were substantially larger than we would expect to see with people getting no treatment just on a waiting list alone. You can see that most people at that 4-week follow-up no longer were reporting elevated depression symptoms of 10 or above. One of the biggest pushes that we've made as a lab is to break out of our bubble of academia. We've been at this for a while, but at this point, to an even greater degree, we see the necessity of involving multi-sector partners, organizations across nonprofit, industry, and advocacy spaces to help streamline and lay the groundwork for sustained implementation of single session interventions. We don't need to be running that many more RCTs. It's really, it's not whether they work or whether they can work, it's how can they be sustained. One example of this is we're working with some state mental health agencies, for example, in Pennsylvania and Connecticut, to test the feasibility and pathways to Medicaid reimbursement for the single session consultation for folks on waiting list. In Pennsylvania specifically, we've gotten a waiver from the state for doing a lot of the regular intake paperwork that's required in outpatient settings, so that clinicians can offer the SSC to people as soon as they reach out for care before they're an official patient, and so that they can bill it. We've received a temporary billing code to Medicaid. And at the end of this trial period, we're going to be able to collect our data and hopefully show to the state, see this is helpful and it's increasing effectiveness of treatment and cost effectiveness of services. And fingers crossed, we'll be able to keep that code permanently. We're also partnering with Mental Health America, a large advocacy organization, Kuth and Alongside, which are wonderful for-profit orgs that actually create school-based digital mental health supports. And we're working with them because they already use single sessions in their intervention suite to independently evaluate their products and suggest recommendations for implementation and iterative improvement. We're also working with CMI, Child Mind Institute, to transfer our SSIs into 2 to 3 minute micro interventions to be embedded in a larger digital mental health platform for youth across California. Last thing I'll say, what one of the biggest takeaways we've gleaned from the work that we've done to date in this area is it doesn't, in some cases, it doesn't matter how scalable you design your intervention to be if there are structural and systemic barriers to youth actually accessing those scalable interventions. Then the design of your intervention becomes meaningless because there's something bigger in the way. And the clearest message to us in this domain was in a recent study that we now have a replication of that we're writing up for publication soon. In a sample of 211 adolescents from one of our studies, in this study, parental consent was waived, so teens could self-refer. We asked teens, have you ever had trouble accessing mental health treatment? A lot of people, more than half, said they had. When we asked those teens, 211 of them, what was the biggest barrier to accessing mental health care when you needed it? About a third said their parents. In our more recent study, about 46% said their parents. So this is a real problem. And it's not always that parents are actively against mental health treatment. It's that a lot of teens don't want to burden their parents, or they don't feel comfortable sharing their difficulties with their parents. And as a result, they go without treatment because in many states, California is way ahead of the curve on this, but still in many states, it's impossible for teens to access care without parental involvement. So I'm really excited that right now we're working on grants that we've received from the NIH Office of Science Policy and from Hope Lab to explore teens' views on parental consent policies in mental health care and consolidate teen suggestions for improving those policies. We're also doing some policy mapping work to evaluate whether the strictness of a state's policy around youth mental health consent and mental health treatment is related to access to care in that state. And ultimately, we're hoping to create a digital dashboard for therapists, teens, and administrators at healthcare settings to use to streamline policy advocacy and change in this domain, and hopefully to enforce policies that are in place, which I think are intermittently reinforced. And last, I've loved over the years talking to mental health professionals about all of these ideas, but ultimately I think part of implementation and dissemination is going to be communication, which is really the why I wrote this book about single session approaches, which I'm hopeful will start conversations outside of academia, not just within, about how different kinds of thinking about what treatment can be and where it can live can help our mental health care system. All right, thank you so much. 7 minutes for questions. I hope that allows at least some time. Thank you.
Wow, incredible. Amazing, comprehensive, rich, and value-driven. I have folks who have asked me to ask a couple questions, or actually, can I call on Dr. Marina Toulouse-Shams? Are you able to unmute?
Yes. Hi, Jessica. Thank you so much for your...
Oh, I think you might have muted yourself. Sorry about that.
Sorry. You'd think after how many years of using Zoom, I would learn how to unmute myself. Jessica, thank you so much for this Amazing talk, and your incredible science and impact on the field. It's just really exciting. Thanks for coming to UCSF to talk about it. I have a question for you. You mentioned about that the SSIs, the data on those with more severe depressive symptoms actually made an impact, which I thought was really interesting in the context of thinking about a lot of the child populations who we work with around trauma. And I'm curious if you have data or can speak to it all, how co-occurring trauma and depression, for example, or how SSIs might have a differential impact for those who have traumatic history. And I bring this up because one of the biggest critiques for our grants with our populations with juvenile legal and foster cares with such significant trauma histories, we always get reviewers saying there's no way one session intervention is going to be able to make an impact. So I'm curious if you could just speak to that a little bit.
Yeah, so ACEs don't moderate outcome either. But in one particular study where we found this, which might be helpful because we have published it now, we were able to partner with folks in Lebanon to test translated versions, Arabic translated versions of our intervention in Lebanese youth and Syrian refugee youth, 100% of whom had a substantial trauma history. Project Personality was the intervention that we translated that's now freely available in Arabic. And we didn't find any differential impact of the intervention on hopelessness, self-hate, acceptability as a function of trauma history. And benchmarking the effects among US populations, they were larger, which fits with a recent meta-analysis in Journal of the American Academy of Child and Adolescent Psychiatry, that in general effect sizes for youth mental health programs tend to be larger in low and middle income countries than higher income countries, which is super interesting. Highly recommend that paper, which I'm not at all involved with. I just really like it. So yeah, I think we're starting to get that evidence, but I do think there hasn't been a lot of work to adapt these interventions specifically to populations with complex trauma. I have a postdoc coming in the fall that's specifically going to be working on that, which I'm super excited about. But we'll be happy to talk further. I think particularly because of critical incident stress debriefing and that whole fiasco, there's a lot of resistance among trauma-focused folks in general, and I totally get it. But I think highlighting how this is not CISD and the differences, we're not forcibly re-traumatizing people, can be helpful.
Wonderful. Thank you.
Dr. McCracken, you put a question in the chat. You can go ahead and ask.
Hi, Jim McCracken here. Thanks for sharing your really impressive body of work, and I find it very, very provocative. I'm interested in as a clinical trialist about your thoughts on what efforts you made to protect against the bias in measuring the impact of these interventions. My impression is that most of the data that you got was primarily self-report from participants. Did you have any sub-studies in which you took pains to try to get independent confirmatory data on response? And likewise, what's the longest term follow-up that you have to better appreciate the durability of these effects? And lastly, did you recruit with incentives to participate?
I have answers to all of those questions. The first question, the first RCT I ever ran was both with parent and youth report. And the reason that I created a placebo SSI as a control condition was to control for that self-report bias. So we ask, do you think you can guess if you were in the new intervention group or the control group? People do not guess successfully because the placebo SSI feels like what they imagine therapy to be, which is like, share your feelings with people. It'll help you feel better. So they're equally acceptable. both the control group or the control SSI and the active one. And we've seen in multiple trials that parent report pretty much corroborates youth report, sometimes with larger effects than youth report. So yes, let's see, your other question. Well, your incentives question is a really good one. We actually published a paper comparing studies that were pragmatic evaluations versus studies that were clinical trials that paid people. And we found not difference in effectiveness, but differences in retention, which is 0% surprising because when you pay people, they finish it. And when you don't, they don't. So the primary impact we see there is that money helps people do follow-ups and complete the intervention itself. In the absence of any incentives, we see about 40% of youth completing an SSI among those who start one, which for a digital intervention, as you know, digital mental health research is actually a big success in terms of completion rates. The second question I'm blanking on now, but I had an answer.
That's cool. If you would allow me just one follow-up. As you said at the very beginning, you're not proposing that SSIs will replace all of us, right?
Right.
We won't be replaced by a bot or an undergrad.
No.
So what are your thoughts about how to integrate these very cool interventions into a mental health system like ours, which is so complex and treats people all the way from the mild end with perhaps more transient symptoms all the way to the most severe?
Yeah, so I think some of the examples I shared represent my thinking around where this could be embedded. So in the context of primary care screening, for example, offering SSIs at the point of detection of difficulties, in mental health spaces, offering the single session consultation either in emergency departments at bedside, which we've done with Phoenix Children's Hospital, or as a waitlist focused intervention for folks who are facing long waits and are kind of stuck in between different levels of care and need something immediately. I think that the single sessions are also, I spent 5 years not doing that in my current position, but in my former position, I did a lot of clinical supervision, and a lot of my supervisees would use SSIs in their sessions to structure a session and as homework as well for folks to complete between sessions to augment what they were doing and reinforce different ideas. So I think there are lots of ways to integrate into healthcare. Admittedly, the work I get most excited about is how to reach people who aren't in the healthcare system and help close that gap between people who need support and people who get something.
Thanks very much.
Thank you so much. I know we went a couple minutes over. Thank you for your time, Dr. Schleider, and thanks for everyone's time. We could be here for another couple hours, but we don't have it. We'll have to invite you back. It's been such an honor.
So much.
Take good care.
Have a good day, everybody.